President.
Where have I gone now? Yeah, I'm back.
We are live, you can start now.
Yeah.
Hello and good evening, everybody. I am Dr. Shunetra Mondal, consultant endocrinologist from West Bengal, India. And on behalf of the Endocrine Society of India and the South Asian Federation of Endocrine Societies, I extend a very warm welcome to our honorable patrons, eminent speakers from across the safest countries, and all our viewers for today's digital session on the eve of World Diabetes Day. Today's theme is technology for diabetes care and access. No doubt, this topic for discussion is perhaps one of the most relevant ones in the context of diabetes management in the current age, and especially for our new and next-gen people living with diabetes. And it has possibly assumed even more importance after the pandemic and lockdown posed a lot of hurdles on physical visit to the healthcare facilities. It's our honor to have the patronage of Professor Dr. Sarita Bajaj, Madam, Dr. Sawar Malik, Sir, from Pakistan, and Professor Dr. Shubhankar Chaudhary, Sir, for today's conference. Of course, none of them needs any introduction to any of us. Professor Dr. Sarita Bajaj, DM Endocrinology from the prestigious Institute of AIMS, FRCP, and a fellow of multiple academic bodies like ICN, RSSDI, UPDA, and ICP. Currently, she is a consultant endocrinologist in Prayagraj, Uttar Pradesh. Ma'am was the former director and head of the Department of Medicine at MLN Medical College, Prayagraj. She had shouldered a lot of prestigious responsibilities, having been the former president of the Endocrine Society of India from 2010 to 2011, founder president of SAFES, president of RSSDI from 2016 to 2017. Ma'am has been the editor-in-chief of the 2 volumes of ESI Manual of Endocrinology. She has established Diabetes Education Foundation at Prayagraj way back in 2001. Apart from having delivered a number of prestigious orations, Ma'am has an oration to her own name, Professor Sarita Bajaj Oration, which was established in RSSDI UP in 2018. More than 200 publications in multiple journals and book chapters, and also editor and editor-in-chief of several monographs and books. Ma'am was conferred the Lifetime Achievement Award in the field of diabetes and metabolic disorders by Diabetes India, as well as for her contribution to Uttar Pradesh Diabetes Association. Ma'am's areas of research interest include endocrine education, thyroidology, obesity. Very warm welcome to you, ma'am. Also, we welcome Dr. Sarwar Malik, eminent endocrinologist from Pakistan, FCPS Endocrinology from College of Physician and Surgeon, Pakistan, Fellowship in Diabetology, Endocrinology and Metabolism, Aga Khan University Hospital, Karachi, and FCPS Medicine from College of Physician and Surgeon, Pakistan. Sir is currently affiliated as an head and assistant professor at Ayub Medical College and Ayub Teaching Hospital, Abbottabad. Several regional research publications in national and international journals. Sir has multiple awards to his name, and one of his achievement is being supervisor for training of FCPS endocrinology trainees in the subject since January 2018. He has been awarded several gold medals for poster and oral presentation at multiple conferences, including SAFES, and he received Best Fellow Award at Annual Appreciation Evening by Department of Medicine in 2015. Professor Dr. Shubhankar Chaudhary, sir, I am very fortunate to have been sir's direct student during my residentship and still now. MD Medicine, DM Endocrinology, MRCP. Sir is the professor and head Department of Endocrinology at IPJMER SSKM Hospital, Kolkata. He holds a number of official positions, being a member of the Subject Expert Committee at CDSCO, Government of India, founder patron of SAFES, immediate past editor-in-chief of the Indian Journal of Endocrinology and Metabolism, immediate past president of the Endocrine Society of Bengal, and a past president of Endocrine Society of India. several publications in multiple journals, and his current research interests include gut microbiome and gestational diabetes, pathogenesis of Graves' orbitopathy, and biology of fat in different body compartments. A very warm welcome to all our patrons. We are lucky to have stalwarts like you to guide us through today's session in the best possible manner. So today we have 6 interesting topics in 3 sessions, focusing on the role of technology in diagnostics, therapeutics, and delivery of care in diabetes. And we have 6 excellent orators to talk on these topics. Each lecture lasts 15 minutes, after which we have 5 minutes for question answer and discussion by our patrons. Without any further delay, we start the first session on diagnostics. So from testing urine for reducing substances to emerging non-invasive glucose testing modalities, we have actually come a full circle around in terms of non-invasive glucose monitoring, but of course through a path of very advanced techniques, including the continuously evolving CGM machines. And we are very privileged to have with us today Dr. Abbas Raza from Pakistan, and sir will guide us regarding the recent advances in glucose monitoring. Dr. S. Abbas Raza, FACE, he has been the International Society of Endocrinology Executive Committee member from 2018 to 2020, educational editor for the International Society of Endocrinology, immediate past president and founder member of SAFES from 2017 to 2019, founder and past president of the AACE Pakistan chapter in 2015, past president of Pakistan Endocrine Society from 2010 to 2012, past member of the board of directors of AACE from 2003 to 2004, founding member and board of directors for Friends of Mayo, and sir has been conferred a Lifetime Achievement Award by the Pakistan Endocrine Society. We are very grateful to have you today, sir. Over to you, sir.
Thank you very much. And if I may be able to share my slides. All right, there we go. So again, I think I have been promoted as a batsman from 12th position to 1st, just to set the stage for Dina, who's going to come in and score all the points that the scores that she needs to score, and again the other speakers as well. It's wonderful to be in company of friends, starting from all the neighbors within the countries and outside Pakistan. Just to give you what we are going to talk in the next 15 minutes, there are a few questions which always pop up in anyone's mind. And I think when we talk about type 1, and again, when we think of what are the strategies, what are the targets that is in mind, and there are a number of options which come along when there could be a better A1C control and better fasting blood glucose postprandial. And we're going to talk at the end which is the right answer. And the same thing is true with the people who are treating diabetes as well. What are the thing and thought process which are going in our mind as when we talk about the glucose monitoring? I'm going to just set the stage for what do I mean. So if you look at the diabetes world and look at the blood glucose monitoring, we know that diabetes is something which has been there from a long time. We kind of know, we get the scriptures from ancient Egyptian documents that it was there. But if you look at the methods of how it was evolved, apart from some data from the before Christ, I think in 1770s, we started hearing the name diabetes, which is like honey. And it took us about 3-4 years to realize that the urine was sweeter in 1674 when Dr. Thomas Willis described the diabetes urine. But then in 1776, the doctor came along and he described the higher level of blood glucose in the urine as well as in blood, and probably not the best of the ways that we used to check blood at that way. They were actually urine tasters and the blood tasters who can taste the urine and say it's a sweet and make a diagnosis. Not, thankfully, that technology is far gone, and again, we don't have to do, and we don't have to delegate someone to do that. I think the real breakdown came in, the really breakthrough came in the Middle Ages, when actually flask called metula was used to look at the urine color and the texture, and look at the metabolic disorders which could be there. In 1930s, we saw the introduction of the Benedict test, and how that could be utilized in Bunsen burner, and using the urine samples and detect the blood glucose in it. So again, that's the history of the urine being tested from 1670s to late 90 to the early 1930s, when we saw the urine being involved. And I think I show you here a quick circle of how the urine was tested, and chemicals were added to look at the metabolic, and just a reminder of how we have evolved over years. But the story of the blood glucose monitoring comes in mainly into in 20th century, when it was tested in the blood. But till 1960s, we were not able to actually make it a commercially viable product, till the dextro sticks came into being in 1964 by MS Company, which kind of evolved, and further development. It took us another 10 years to develop devices which could actually be first glucose monitoring devices by MS meters. We are called ARMs. They were in use for a long duration looking at it. It was around in 1970s also when the test called A1C came into existence, and again then it became a standard of care. So if you look at the history of the blood glucose monitoring, at every given era there was something which was made as a gold standard, starting from urine to the blood. Then it took us another 20 years to kind of make use of our interstitial fluid, and I think that was also a groundbreaking invention as well. And the reason I tell you is that from urine to blood, we kind of evolved and got much information from it by checking the blood glucose levels. But then the interstitial fluid gave us the idea of the glycemic variation, the time in range, and these are the things which I'm going to briefly touch, and I think it will be touched later on in the presentation as well, which evolved from the institutional. What about the newer innovations? We are looking at other wonderful things which are coming in. The more authentic ones which are coming along are biosensing, the contact lenses, which might be able to not only detect the early changes in the retina, but also detect the blood glucose from when you're wearing it. So it seems like not going to hear about them in near future, but definitely more and more is coming out. And the other big development that we are seeing actually are the biosensors, which can actually detect the blood glucose in the saliva. So this is just the preamble of what is coming up in the fair. And the salivary blood glucose is somehow correlated with is related to the blood glucose by a certain mix and match. And again, you can actually get an idea of what it is. And if you think of saliva being telling you your blood glucose, that opens up a whole era of how we can check our blood glucose. So what is a patient-centered approach? We've always talked about using the insulin and using the blood glucose markers as centers of care for our patient population, which includes the A1C and fasting blood glucose. But how often are we achieving it? Not really. And partly the reason is that whatever modalities we are using at this time, which includes the blood glucose monitoring or A1C, sometimes it does not reflect how we are actually, how the patient is going through, how the situation with the patient is. And again, and the medical modalities we have not been very successful in controlling the blood glucose our patient population. And it's a multifactorial thing. There's a lot of confounding factors associated with it. Let's talk about few of them. And again, one of the things that we've always used is A1C, and we know for a fact from the UKPDS and DCCT trial that there is no limit for benefits of bringing down the A1C. The lower your A1C, the better the outcomes are, and everything looks better as far as retinopathy, nephropathy, neuropathy is concerned, and getting the benefits of the microalbumin is concerned. But there are innate problems with A1C. Some of them I'll discuss later on as well. But if you look at the A1C and the hemoglobinopathies that we face in our part of the world, the A1C is not something that we can 100% rely on. So that's something that we need to look into. And there's definitely inter-individual variation and ethnic differences in the A1C. And on top of it, whenever we are trying to target A1C and we try to bring down the A1C to lower, if you can see on the marked areas that you can start seeing hypos as well, because the A1C is the average. So to get a good average, sometimes we end up getting more hypos. And I think that's the time that most of the organizations now are talking about beyond this A1C control, beyond this, and the things that we talk more and more is about the hypoglycemia, the hyperglycemia, the time in range, and all these concepts. So it's a balance that we have to create between getting the glycemic control and not getting patients into hypoglycemic or the loved one into hypoglycemic, getting the glycemic variability, time in range, and weight gain into perspective as well. So if we, unfortunately, we've been playing this seesaw game in which if we try to control one, the glycemic control gets out of hand. If we try to control the other again bit. What is glycemic variability? Actually, it's the changes in the blood glucose in hyper and hypo and within the euglycemic range. And just to give you an example, again, most of us are familiar with this concept, that if you see this person who has an A1C of 7.8, and if you look at this person is also has an A1C of 7.8, both have a very different glycemic control. So the variability in the glucose is huge in patient B versus patient A. So does this variability actually translates into, and this is very interesting data that is emerging as well, in which we can look at the variability. And if I just want to give you an analogy of this, that if you remember, the heart rate variability is also a risk factor for coronary artery diseases and other problems. The same way, the variability in the blood glucose in this study was seen in critically ill patient. And if you can see the green, which is the lesser variability, and red being higher variability, even at a lower blood glucose level, people who have higher variability ended up getting more mortality in these individuals. And again, this is not only limited to mortality, it was also related to severe hypoglycemia, in cardiovascular endpoint, and even all-cause mortality with a significant number. So something that we need to be worrying about, and we'll hear more and more. The other concept which is similar to it, and thanks to the interstitial fluid and continuous ponding, we can feel it. And the time and range as depicted in this one, the two people, one in blue and one in white, have the same A1C, but the person in blue has a much more time spent in green area as compared to person or the other one. And again, time in range actually is something which the type 1 diabetics and the people who are suffering from variabilities are requesting for more and more control. Are there a benefit? Again, quickly going over the frequency of your retinopathy and microbillion, both is much lower if your time in range is high. Even in pregnancy, if your time in range is 25 or less, your chances outcome is much better. So again, anything less than 40 and remaining above 70, 60, 70 in pregnancy results in better outcome as compared to anything else. So what do the type people with diabetes want? Actually, they want better control, better time in range, rather than focusing on the fasting or the postprandial or anything else. So these are the things which I've learned, and I was able to communicate to you in the short duration that I have, and I'll be happy to take question but one thing that I think we should all be thinking of, that instead of focusing on glycemic and fasting blood glucose, we are now looking more and more into other parameters of diabetes care, and this is something which is going to evolve. So the days of urine testing is pretty much gone, and again, you can now actually do not want to check the urine for blood glucose region, because the SGLT2 will pour blood glucose and will pour glucose in the urine, and that will always give you a false reading as far as glucose. So the blood glucose monitoring is still something that we are counting on. But I think the newer technologies in diabetes management will help us decide a better outcome, better A1C reduction without causing much of the trouble. So it's at the end of the day, it's the balancing act of glycemic control versus controlling the side effect. And if we can find a better way to somehow balance these and and improve the quality of care, and that's the way forward for our patients who are suffering or living with diabetes on a daily basis. With that, I thank you all and give the podium back to the organizers. Thank you.
Thank you so much, sir, for that excellent presentation. So may I now request our patron, Dr. Sarwar Malik, to please lay his valuable comments. So you are muted, sir.
Am I audible?
Yes, sir.
Yes, you are. Yes, you are.
Thank you very much for giving me an opportunity to patron this very important program on technology for diabetes care and access. We have 3 sessions in this. The first session, which has been done by Dr. Abbas Raza, as always was fantastic and telling us the advances in glucose monitoring started from the history of testing glucose from urine, then to the blood, and then from interstitial cells. And now there are some advances as it can be detected from the saliva as well as from the contact lens. So I believe the important advances as coming in diabetes are definitely for us, but majority of our population can't afford the advances in technology. We all realize that it is very important to control HbA1c, fasting blood sugar, as well as random blood sugar to reduce the cardiovascular morbidity and mortality. At the same time, we have to much focus on, along with the control of diabetes, in the preventive strategies, because prevention is the most important factor. If we can't prevent or if we can't delay the diabetes, it would be very difficult, especially in South Asian region, to have benefits of the advanced technologies. Most of our patients even can't have access to the basic needs, like about 50% of the patients, they can't have even access to the insulins and the basic medications. So the most focus should be on these basics, that the most of the patient can have access to the basics. Thank you very much for inviting me and giving an opportunity to be part of this faculty. Thank you.
Thank you, sir. Ma'am, would you like to add anything or place any comment?
I'm muted here. I think we'll go on with Dina's talk because the diagnostic part is in one.
Okay, ma'am.
And then we'll come to that. Okay? Yeah.
Thank you, ma'am.
Yeah. Thank you so much.
Yeah, so the current generation is the era of everything instant and stat. So in the hurry to have the instant results, are we compromising on the quality of the tests? So I welcome Dr. Dina Shrestha Madam from Nepal to enlighten us with her views on current status of point of care testing for HbA1c. Ma'am has already started.
Okay. No, I'll stop it. Okay.
I'll just introduce you, ma'am, for those. Of course, you do not need any introduction still. So ma'am is currently senior consultant endocrinologist at Norvik International Hospital, Nepal, and the president of SAFES. So over to you, ma'am.
Thank you so much for that kind introduction, and thank you. I feel honored to be in the presence of all my seniors and eminent speakers. So I could not understand why Dr. Abbas was saying that he's batting or bowling, but after his presentation, now I understand, because I think my topic is about HbA1c, and I think he just batted against it. So, but I hope I can convince you that though there are, like Dr. Abbas said, there's just no denying that we have, there is a place for in-time control, and there is a time for, there is a place, of course, where we're checking the fasting, postprandial blood glucose and interstitial blood glucose. But no matter what we say, the point of HbA1c that we've been talking about in this last decade, I think cannot be undermined. So in this digital era where, you know, we want our smartphones and we want to be on Instagram and we just want everything to be liked and everything to, we know we want it now. I think that point of care testing for HbA1c is important, and we can see that that how historically HbA1c, though it gives an average. I do understand that and I do agree that if the average depth of a river is 5 feet, at some point it can be 7 feet and somebody can drown in that, So we do understand that there is glucose variability, but enough studies since 1958 when HbA1c was first recognized, and then they realized that in diabetic patients that actually HbA1c is raised and it has an importance in diagnosis. Its clinical use has become the cornerstone of our clinical practice. And we all, I think, who are present here have faced that problem where, where we were talking about fasting and postprandial sugars, where we were talking about random blood glucose and its importance, but also how we were facing the fact that the HbA1c that we did was not standardized, and that the methods that we were using in different labs across different countries had different reports and the significance was not concordant. So we can actually, HbA1c has gone a long way. So from various principles of testing like ion exchange, affinity chromatography, electrophoresis, colorimetric assay, and immunoassay. And then there were others which was evaluated, compared, like micro and mini columns, low pressure liquid chromatography, high pressure liquid chromatography, so manual assess, automatic assess. So I mean, really, like, this is one test that has, because we knew that it is important, we knew that it can be used, but we were not able to get the correct way to standardize it. And with that evolution, what happened is that in the 1990s, HbA1c, because of these issues, there was in the US, the National Glycosylated Standardization Program was implemented. And because of that, today, we know that if we use the standard, and which was used in the clinical studies for DCCT and UKPDS, because as we know that in that, when the HbA1c was used correctly and it was measured correctly, we could see that even 1% of change in the HbA1c actually could lead to a lot of complications being ablated. So just 1% reduction could bring down heart disease, and 1% of HbA1c reduction could bring better retina, could decrease retinopathy. So what they did is that they put together this group and then formed this national, NGSP that we call, and then called on all to the labs that we standardize the HbA1c accordingly. And most of the labs now actually use the HPLC, the high performance liquid chromatography, and that is considered to be a gold standard for HbA1c analysis. But I do agree with like Dr. said, that not everybody can afford it, but any place that can afford it and can use it, this is a good test. Obviously, there are caveats, like Dr. Abbas did put in a slide, and it's true that if you have anemia, if you have a hemoglobin variant, you have chronic renal failure, you have disorders in iron metabolism, your HbA1c is not going to be correct. But at least it gives you an idea of where you are. Like, even a person with chronic renal failure with anemia, if has an HbA1c of 8, we know that, okay, he's really not in control. In theory, it might be 10 or 11, because with a hemoglobin of 9, if he's showing an HbA1c of 8, we know, but it will give us an idea that that this patient is not under control. So I would say that the significance of HbA1c cannot be undermined. We know that HbA1c reflects the blood glucose of erythrocytes for the last 3 months, and it is a good index of glycemic control. And we know that 6.5 and above is diagnosed as diabetes, as according to the HADA, and normal is below 5.7. I always make it a point to check the hemoglobin along with the HbA1c, so it at least gives us an idea that this is not false positive or negative. And where we are using it maximum now, as for me, is also for preventive. Like our good doctor said, that the way to go is pre-diabetes. Treatment of diabetes is already in a way of failure of the society, failure of our healthcare providers, failure of educators. So we need to catch them at pre-diabetes, because the data from somebody presented in the EASD was that actually, if the diabetics in the world is about 8.9 to 10%, almost the pre-diabetics is reaching 30 to 50%. So it is our job, our duty to stop these patients from becoming diabetic. But if we actually check just the blood glucose in pre-diabetics, we know that it will be normal. And if they think that they're not pre-diabetic, it is very easy to go the other way, go up to red rather than the normal green. And good thing about HbA1c is that it can be performed at any time of the day and did not require special, like we don't need to be fasting or anything. So the role of HbA1c, again, I would say is that it is used for now diagnosis, both by the ADA and WHO. I think ADA was first to adopt and WHO came along the way. A value of less than 6.5 does not exclude diabetes, because you can just be recently diagnosed because it's not been 3 months. You've just got hypoglycemia in the last 2 months, and it might not reflect so high in the HbA1c. So we do want blood glucose monitoring too, but along with HbA1c would tell us as a good predictor. It's a good 2-point testing. And I mean, we all like Dr. Sarita Bajaj, Dr. Abbas, I'm sure we all have been in that clinic where we have these patients, and we know that though OGTT is a gold standard, and we know that that will tell us 100% that this is the patient is diabetic, but we know that it's a bit inconvenient if the patient is from out of town. We all are privileged to be working in big cities where we have access to health, but we know that we all have centralized health system where we don't have very good decentralization of health, where at the village level or at a smaller city, patients don't have access to healthcare, and they all come to our cities. They don't have like the hotel stay, or the dynamics may be different. They might have to go home because they've left a baby or an ailing mother home, so they want to go back. And so to tell them to come back in the fasting, then again do an OGTT postprandial might be difficult. So at this point also, I think HbA1c with the random blood glucose may be a good way to actually diagnose diabetes and to screen people with high risk. So sometimes patients come, but we see that the son is overweight, or we see that that the other person also might need. So we might just be able to screen the family also with that. So coming to the point of, like we say, technology and, where we all are on smartphones and Zoom links. So where we need access to everything. So clinical point of care is a point where the clinicians can deliver healthcare. And we have been doing that with blood glucose monitoring. I remember in the beginning, even now, whenever there's a patient who's a bit anxious, and if I tell them, okay, I'll check your blood sugar now to see whether it's really high or not, because they're not sure that the lab is correct. And when I do it in the lab with the glucometer, a simple test, they feel so much happy. Or like when we had the COVID, having the pulse oximetry, just to say that your saturation is above 97, like that was good. Any patients with kidney disease, where the urine test strips we can use for albuminuria, especially with children who have nephrotic syndrome. I think those are the things that have always been there, and we've kind of enjoyed that POC, point of care, from the physicians and for our own homes. So now that we are doing point of care testing for medical diagnostics testing, I think that this is an era, this is the 21st century, where we have to adopt and adapt these technologies. The advantages surely being that the results are available immediately. There's definitely going to be an ease of use, because anything that is made at point of care cannot be very, very complicated. And there's a shorter analysis time. Definitely, like I said, patient satisfaction and engagement is going to be maximum. For the now that we think globally, I think the Glasgow climate change is going on. So we know that it has a smaller footprint, and that it is less demanding in terms of training and maintenance. Having a lab assistant and having a point of care technology where you can just use a device, definitely the process is much more simpler. The POCT HbA1c devices that I looked up and I could find that were actually good and ready to go were actually the FE1 HbA1c and the DCA Vantage. I think these are the ones that have been maximally studied and been used. A1C now is also over there, but with the Cobas and Biorad. So we have these things, and actually recently in 2020, the NHS also ran a big study, but it wasn't a randomized control trial, but a evaluation for all these systems that are there, and it's a good read if anybody wants to find it. And they have actually enough studies, like the Sobolewski study about the Effion, the Abai study also on the Evian, and the Lentes Vestra study from the Netherlands. They all have actually been up to par. Nobody has actually disappointed us. The way, HbA1c came a long way, and how blood glucose testing has come a long way with the glucometers. Even before, we had a trust issue on glucometers that it shows high, or it's not reliable, but now we use it. Same way, even the POCT for HbA1c actually is now pretty good. And the only study that was done was in New Zealand. And actually, what is said is like, I think it's the same. Like it's just like history has repeated itself. The way for the glucometer, how we said that there's finger food, and then we have to wash our hands properly. We have to make sure that there's enough capillary blood. Same thing, I think, for HbA1c also. What they said is that it is very much reliable. It is also reproducible. But what we need to do is, because it's a bit more complex, so they need a bit more extra training. Like, you can't just get it home and start doing a POCT for HbA1c, right? But definitely the portability, the clear advantages that, where there are no laboratory services. If I will show you where I went for a trek in Langtang. There you cannot imagine a lab, but if you can get a POCT and we can diagnose diabetes, that would be excellent. But it does need internal quality assessment. It does need an external quality assessment, and it does need some kind of training. And when I actually read this, I thought, okay, why? Like, isn't it just supposed to be like a glucometer? Why would it be so difficult? And then actually I saw that, okay, the HbA1c, the gadgets are not as compact as our glucometers, and they might need a bit of training, but that training is not unachievable. I would say that even the health assistants would be able to learn it, or the nurses, diabetic nurses, would be able to do it. So if I have to summarize that, the guidelines that what we follow, the ADA, the IDF, the NICE, that what do they say about the point of care testing in HbA1c is ADA says that although point of care ASC may be NGSP certified, and it should be, as we all know, because that is the only reliable HbA1c we can compare to, the proficiency testing is not always mandated for performing the test. Therefore, point of care assay approved should only be considered in settings of license to perform moderate to high complexity tests. So it means that just don't give the machine and say, okay, use it. Like, train somebody, try to tell them how to use it, and make sure that, because these are not cheap, and the tests, because once you're screening, not only for diagnosis, but if you're screening it, it's important that the person understands the gravity of the result that the person will give. The IDF has no recommendation. And they, like I said, like WHO and IDF is always one step behind. So they kind of will follow along, I feel, once more and more studies prove that the POCT HbA1c is equally reliable. And I think there are enough studies to prove that now. But they are saying that, no, do the lab testing and don't go for the POCT kind of thing. No special recommendation. And with the NICE, which includes the POCT, should conform to expert consensus reports on appropriate use and national quality specification. So use devices that have been approved, just not make sure that they have the NGSP, the FDA approval, they have done their work, and the staff is trained. So that, I think, is a doable thing. So the gadgets I showed you. Definitely the way ahead is that we need future research studies to compare different screening strategies, whether we just still the OGTT will be the gold standard, whether a postprandial glucose is enough, and whether the HbA1c versus fasting in a POCT setting is good. I mean, the way ahead will always be the randomized controls trials. And what we also want to see is whether the diagnostic accuracy, considering the clinical and cost effectiveness, because they are not cheap. Like the way glucometers, the blood glucose testing is cheap, HbA1c is not cheap. So I conclude by saying that moderate quality evidence has shown that there's positive POCT HbA testing is actually not so bad compared to the laboratory HbA1c measurements. And this is a quote unquote from the NHS study, but really 5 observational good studies have shown that they have good assays, and that when compared to the HbA1c, which is supposed to be the gold standard, it is still good enough. And that is being put for the FEON and the DCA. So there I was up in the mountains. This is almost 6-7 days hike of 8 hours a day. And I thought I was posing good when somebody took over, like Dr. Abbas, like literally the best pose ever. And I would really want to welcome everybody someday to have a physical here so that you can enjoy the mountains. We can see where POCT is going to be accessible, and you know how everything will be physical one day. So I look forward to everybody's presence. Thank you.
Thank you so much, ma'am, for the beautiful presentation. May I now please request Dr. Sarita Bajaj to take over and place her valuable comments.
Okay. So do we have any Q&A in the chat box?
No, ma'am, not yet.
Okay. So thank you, Abbas. I really enjoyed the talk, and Dina's as well. I just see, we do talk about all these modalities as far as diagnostics is concerned, whether it's in the context of glucose monitoring or the point of care. But what I thought was most relevant was what Dina said at the end, that how do we get more people? Isn't it? Abbas and Dina, the question is, I think applies to both, because the same thing we have in India. So Netra, I'm sure you agree with this. Dr. Sarwar will also agree with us that the majority of our people are in the rural area. Even to get them to buy a glucometer is well nigh impossible. Yeah, they'll buy it, but how to use it? And any instrument is only as good as the person behind it, or the machine behind, or any machine or instrument is only as good as the person who's using it. So number one, the proper training. That's exactly what Dina tried to point out. Number two, the easy availability. How to train the individual to use it correctly. Because I think we've had a lot of mistakes, a lot of errors, and they are actual technical errors. How do you store those
Reagents?
Strips? How do you look after them? Point of care, Dina, I think one very relevant point is that it needs to be kept in under a certain temperature. It needs an air-conditioned environment. I don't think you can, and that's what I've understood from these point-of-care HbA1c machines, because they will not tolerate a 35-40 degrees. And when it's very cold, this is what I understood. What do you have to say in that context? Are they temperature sensitive, or you can place them under any temperature? Point of care, not the glucometers. Even glucometers,
you live in Lux.
Beg your pardon?
No, so I don't know, any temperature can become 55 degrees. So, and I think what Abbas also. So for us, yeah, but I don't think so. This point of care, they are not very sensitive to temperature, ma'am. I think that they are good for the room
you
temperature.
You can place them in any room, I'm trying to say, yes, irrespective of
the portable, yes,
temperature. Okay, because what I thought was that they need a conditioned environment to be able to function properly. For example, even glucometers, like some people, if you carry it in a car, it becomes very heated if you leave it behind. So all these temperature sensitive things need to be considered as well.
But that is true for, I think, everything, that extreme temperatures would finally break down the agents. But overall, the POCT, the ones, FEON, and they are quite good and reliable and portable.
Yeah, so I'll come back to that question. How do we make sure about these aspects? Number one, the availability, the understanding, and how to get people to actually use them, because that's very important. Because they measure the frequency, the duration, the magnitude, the distribution of glucose exposure, the variability and stability under conditions of daily living. And I think, like Dr. Sarwar said, absolutely agree with him. This in turn will lead to more precise therapies, resulting in improved outcomes. So if we want better outcomes, whether it's SMBG, whether it's CGMS, whether it's flash glucose monitoring, all these are extremely important. And like you said, point of care. When the patient walks into a clinic with a very high random blood glucose, but the A1C is nice, 7, maybe 7.5, between 6.5, 7.5, then you can reassure the patient, yes, something has happened to make your blood glucose go up all of a sudden. So the value is there. But how do we get them more in use in our setup? Abbas, would you like to take that first?
Dr. Sarita, it's a very and again, that's the dilemma that honestly we've all faced in every aspect of diabetes. And we were having a discussion slightly on a different note, but again, we did the use of GLP-1s versus not using in population which cannot afford it. So I had an argument that it's almost I'm not sure how politically is correct or not. It's almost unethical to write a GLP-1 for someone who cannot afford, because then it will ultimately result in something that he has to compromise on in his real life. And now on the other hand, it's almost unethical not to write a GLP-1 in someone who doesn't have a problem when he can afford it, and not give him the benefits of the GLP-1. I would think the same would go here as well. I think it's difficult to think of time in range and the glycemic variability in someone who cannot afford it. So I think we'll have to improvise on whatever we can get. Even getting a urine sample sometimes becomes a challenging in these situations. On the other hand, we have to utilize the best of what is available for people who can afford it and can use it in bigger cities. And again, everything is available in bigger cities in Pakistan. And again, obviously, the poverty has hit in the lower cities. So I think it's the judgment call. And this is why I think, Dr. Sarita, you are still practicing medicine after doing it for the last 50 years, because we continue to practice. We never master the medicine. We always do practice of medicine.
There is one question for you. And how is this, Dr. Robin Maskey wants to ask, the saliva, that method that you said, please clarify how sensitive specific it is. He wants to ask that from you.
So Robin always asks the most interesting question in a group. So I've known him for too long. So if I tell him that if I can go over, the salivary glucose can be monitored just by checking your saliva, and actually it can be matched with a certain method as well. Again, just to give you an example, if your in your saliva, if your concentration of blood glucose is 1.02 milligram per deciliter, it corresponds to a blood sugar of about 100. And if it's around 1, it's 2.3, it corresponds to the blood sugar which is ranging in about 200 plus range. So it's actually it's a different form of standardization. You can check the blood saliva and look at the glucose content. Still, it is a long way to go because the typical standardization is not done yet. But now we are learning more and more that you can check your saliva, look at the blood glucose, and correspond that to the blood glucose. And I think the more AI, artificial intelligence, and things that we can use probably will end up getting more information. And that's why still it's not commercially available, because there's a lot to be learned. And the same is true with the tier content of blood glucose as well. So these are all innovations which might be coming in years to come.
Thank you.
I hope I answered your question, Robin.
Yeah, I think Dina has already answered this, Robin. The specificity and sensitivity of the point of care A1C test compared to the NSPG HbA1c. I think she said that
yes,
they are pretty
F1,
comparable.
it's almost 95 plus %, and for only for the I think Cobas it is about 77 to 80%, but most of them would correspond with the lab to almost above 99%. So that is, but this is not a controlled trial, but meta analytical studies that actually.
Thank you. So thank you, Dr. Abbas, and thank you, Dina. Thank you so much. I'm honored to be invited here. It's a pleasure to have this is the 6th day, right?
Yes,
the 5 days of the public program. Congratulations to Ganpati as well as to Dina. And I think Abbas had said a very good, he showed the excellent work that he did, which Dina is carrying on as the president. So thank you both very much. Over to you, Sunetra.
Thank you so much, ma'am. So we start our next session on therapeutics. So possibly nothing has contributed more to the improvement in the quality of life of people with diabetes, so much so as the insulin pumps. And today we have Dr. Harshal Ekatpure, consultant endocrinologist from Ruby Hall Clinic, Pune, to take us through a journey across the generations and through all the loops and loopholes of pump. Over to you.
Thank you for the introduction. So I will try to be as brief as possible, and I'm very glad to be part of this prestigious event. And today we'll be discussing the insulin pumps, basics and beyond. So the topic's name is basics and beyond. So I'll start with the basics. Now we all know the basics of the pumps, but still I would like to go through some basic aspects of a pump therapy. The ultimate goal here is full normalization of glycemia. That is what we are thriving to achieve. And when we discuss HbA1c, time in range, the end result is always the normalization of the glycemia, and we want to mimic the physiology. So whenever we eat meals, there are spikes of blood glucose levels at the baseline. There is a baseline insulin secretion which is ongoing, and when we give a basal bolus regimen, we try to mimic this physiology, but it is not always possible because of the limitation of insulin which has been administered from the outside. So when we manage this diabetes, particularly type 1 diabetes, we are kind of walking a tightrope here. Hyperglycemia, its consequences like retinopathy, nephropathy, the cardiovascular complications mostly we want to prevent by preventing the hyperglycemia. At the same time, we want to reduce or minimize the risk of hypoglycemia as well. And balancing it is actually a very walking like a tightrope, especially in a type 1 diabetes kids. It's very difficult, and that can lead to significant consequences, psychosocial, financial, and of course in long-term morbidity and mortality. So when we think of reducing these complications in long term, as well as at the same time when you want to reduce the risk of hypoglycemia to the patient, that's where the pump therapy comes into the picture. So what patient actually needs is a more physiological insulin delivery. When we do that, there is of course increased time in range at that time, and that prevents the cardiovascular risk in future. So to start with the basics of insulin pump, we all know it's a battery operated device. It contains the reservoirs of insulin similar to the regular syringe, and it holds for 2 to 3 days. Computerized battery operated pumps. The pump you see here is quite a recent or advanced one, and it is connected through a thin plastic tubing called as infusion set, and it fits on the skin, usually on the abdomen, and then it continuously administers the insulin. The part of the pumps, we all know there is one cannula housing, adhesive tape and tubing. Now when a patient inserts a cannula, that is the most important part here, because most of the times or sometimes if patient is not trained properly, the cannula does not go into subcutaneous space and the insulin can go waste, and patient can land up with the diabetic ketoacidosis and other complications. So this is the most important step, the insertion of cannula. And as per the standard body recommendation, the infusion set has to be changed every 2 to 3 days. In countries like India, most of the time it is not possible. Here our patient changes it sometimes around 4th day of every 4 days they change the insulin infusion pumps. So benefits of continuous subcutaneous insulin infusion, whether it is most effective, and what is the advantage over multiple daily injections that we are looking at here. The basal regimen and the bolus regimen, when we see the spikes in the blood glucose levels are different at different times. So actually the boluses sometimes can create problem. Sometimes the basal rate requirements can create a problem, because even in physiology, whatever healthy pancreas does, we cannot mimic it in a type 1 diabetes patient. So our aim is to do that, the bolus adjustment and the basal adjustment, preferably the variable basal rate adjustment, so that we can go as near to the physiology as possible. And when we look at the pumps, they utilize the rapid acting insulin analog in the reservoirs. And the reason for utilizing the rapid acting insulin analogs is the coefficient of variation of insulin action. If you look at the intermediate acting ones, long acting ones, and the rapid acting ones. So rapid acting ones has the lowest intra-patient variability when it is administered via continuous subcutaneous infusion. That's why the utilization of a rapid acting insulin gives more steady basal rate in particular patient. Similarly, with pump, you can design the different rates for basal infusion. Many patients, or many type 1 diabetes patients, they have different lifestyles. Everybody's exercise routine is different. Everybody's meal timings are different. Day sleep wake cycle is different, particularly when they are working from home, sitting in India, working for the company which is in the US. So for these particular patients, multiple basal rates really are helpful, because if you can program the basal infusion accordingly, you can actually keep the patient under control, and at the same time you can prevent the onset of hypoglycemias, especially those early morning hypoglycemias which are sometimes associated with once a day basal insulin, that can be safely avoided by devising the different basal infusion rates. So pumps provides slightly better control, minimizes insulin variability, and it has a bolus wizard calculator. So any smart pump, particularly these newer pumps, whenever patient checks the blood glucose levels and enters it into the pump, it is recorded into the bolus wizard calculator. Suppose patient's blood glucose level is around 200, and patient simultaneously enters the carbohydrates which are being consumed. So the pumps calculates everything by itself, takes into the consideration active insulin which is already present in the body, takes into the consideration the correction which is required for the blood glucose, and calculates the bolus. In this case, it comes around the 7 units. So this bolus wizard calculation actually helps in terms of administering more physiological dose of bolus insulin in particular patient, based on the amount of carbs that are patient going to consume, and based on the active insulin which is still present in the patient's body. And when you long term, when you look at this continuous subcutaneous insulin infusion in terms of outcomes, so hazards ratio, particularly for fatal cardiovascular events, is particularly better, 42% reduction, coronary heart disease 45% reduction, and 27% reduction in total mortality. So MDIs versus pump, definitely there is advantage in long term in terms of prevention of total mortality as well as the cardiovascular disease. So when we look at the global data in terms of association of insulin pump therapy versus insulin injection therapy, in terms of acute outcomes, especially in kids, particularly with type 1 diabetes, and when we look at the data from the meta-analysis from all over the world, so it has been found that the in a matched cohorts, particularly when you look at the acute events like severe hypoglycemia, hypoglycemic coma, there is a definite advantage of pump therapy. And hypoglycemia prevention is one of the major driving factor behind the pump therapy, especially in the young adults or even kids. Similarly, other acute complication, diabetic ketoacidosis or severe ketoacidosis, pump do have some role in prevention of that also, provided that the person operating the pump is well versed with the insulin pump. Many times, sometimes patients tend to discontinue the pump infusion while doing some activities, and that is more prone for a development of complication like ketoacidosis and other. So that training is more important. And when pump is used properly and devised properly, rates are adjusted properly, the acute complications like diabetic ketoacidosis are also better controlled. So what the standards bodies have to say about the pump therapy? ADA, insulin delivery more accurate than the injection. Of course, the human error is eliminated. Large swings in blood glucose can be prevented if the basal and bolus rates have been well adjusted. Bolus insulin becomes easier, more physiologically you can administer the bolus insulin. Severe hypoglycemia episodes can be less. Unpredictable effects of intermediate and long acting insulin, which I have mentioned previously, with sometimes with unpredictable excess physical activity, and patients who are on long or ultra long acting insulin can experience hypoglycemias. So that unpredictable effects can be eliminated by use of pumps. Similarly, ASE has recommended type 1 diabetes intensively managed and insulin dependent type 2 diabetes patients are good candidates for the pump therapy. And while using the pump therapy, they are more motivated to achieve the optimal glycemic control, and in long run they get improved HbA1c, improved treatment satisfaction both for doctors and patient. Hypoglycemia frequency has been less, and studies have shown it is more effective in lowering HbA1c than multiple daily injections. So when we looked at the basics of the pump therapy, now we'll go slightly beyond and look at the different pumps which are available with us. Now these pumps are actually very costly affair, not just for buying purposes, for maintenance purposes also it is a costly affair for average Indian patient. So most commonly the pump which is still utilized in India is this Minimed Paradigm pump, which is a basic insulin pump. It can be integrated with the CGM. There are no automatic features in this. You have to devise the basal rates differently, and there has to be a manual intervention. So every time patient has to take a bolus, he has to push the button of the pump. This is the most basic pump, and it is the most commonly still utilized pump in India. Advanced one, there are 2-3 patients of mine who have been using this 530 630G system. It has a Guardian sensor. So sensor fits on one side of abdomen, pump fits on the other side of abdomen, and they are connected via the wireless technology. And it has a auto suspend feature. So when you preset a low in a pump, when a pump detects that blood glucose level is particular point, at suppose you set the preset as 80, the pump suspends the insulin delivery and gives alarm to the repeated alarms to the patient. So less hypoglycemia and more time in range with the use of this particularly advanced 530G system can be expected. Coming to the more advanced system, 770G, I have seen it in pictures only. I have seen a demo once, but none of my patients are on these pumps. But it's more advanced in a manner. It predicts, adapts, and self-adjusts. So it's like a broker in a stock market. It not only predicts whether stock is going to move up or down, it takes action also whether to buy or sell, and afterwards self-adjustment in terms of capital is also made. So monitors the BSL 24/7, predicts highs and lows in advance. So it suspends before low. So even it does not actually allow the hypoglycemia to occur. It determines the rate of fall in the blood glucose levels and suspends the insulin infusion. And some self-adjustment in terms of basal insulin delivery is also there. And that can be adjusted based on the patient's multiple parameters. And coming to the last one, that is advanced hybrid, that is closed loop. That is what our ultimate aim is, where there has to be addition of meal detection algorithm for more front loading of the meal insulin, more improved interference and meal announcement. So small, medium, and large boluses can be administered. There could be a pattern recognition by which the pump itself can recognize the pattern based on the 24-hour cycle. Sensor additional inputs like heart rate, sleep, activity, free fatty acids in the blood can be taken into consideration by the pump. and early detection of the sensor or infusion set failure and giving the alarms accordingly. So I think I have covered the basic aspects and some beyond aspects of the pump. And thank you very much for your patient listening. And over to you, the managers.
Thank you so much, Dr. Rekat Pure, for that very elaborate discussion on pumps. So since we are running a little short of time, we will proceed to the next talk of this session. So the last decade has seen an ever-increasing number of arms in the armamentarium of diabetes pathogenesis. And of course, with that comes newer treatment targets as well. And Dr. Alpesh Goel will guide us through the recent and emerging therapeutic targets of diabetes mellitus. Dr. Alpesh Goel is has a very brilliant academic career, currently assistant professor at Department of Endocrinology, AIIMS, New Delhi, and has a number of awards, including ESI AV Gandhi in 2018. Over to you, sir.
Thank you, Dr. Sunetra. And I'll now share my screen. Okay. I hope my screen is visible.
Yes, sir.
Everything is in order. Yes, everything is in order. Please go ahead, Alpesh.
Thank you, ma'am. And thank you to the organizing team for having me here. So my job is to discuss emerging therapeutic targets in management of type 2 diabetes. And it's a very large topic, and I'll try and do justice to it in the next 15 minutes. So we all know about the famous octet of diabetes proposed by Dr. D. Fronzo. And this octet talks about different pathophysiological defects in type 2 diabetes, and also various pharmacotherapy options that can be targeted at these pharmacotherapeutic defects. To this octet, we have other players that have been proposed to be added, such as dopamine, testosterone. We have a recent clinical trial which suggests that testosterone could be used to prevent or reverse diabetes in early diabetes or in patients with impaired glucose tolerance. And we have an ever-lingering player, that is vitamin D and renin-angiotensin-aldosterone system. But even with these pathophysiological players, we have a certain group of patients who fail to achieve optimal glycemic targets, and we always feel that there is a need to upgrade our therapy and find novel treatment targets. And so if we discuss advances in diabetes pharmacotherapy, we can discuss this in two broad headings: non-insulin and insulin advancements. In terms of non-insulin anti-hyperglycemic agents, I'll limit to certain targets such as glucokinase, glucagon receptor antagonism, 11-beta-hydroxysteroid dehydrogenase antagonism, dual SGLT1, SGLT2 inhibitors, which have gained rapid momentum in last few years, incretin therapy, which includes GLP-1 plus GIP receptor agonism, and GLP plus glucagon receptor agonism. In terms of insulin therapy advancements, I'll go on to discuss once a week insulin therapy and a brief word about alternative routes of insulin administration. In interest of time, I'll not be able to discuss smart insulin or glucose responsive insulin, thermostable insulins. And also there have been various advancements in insulin pump therapy, which were discussed very well in the last session. So coming on to glucokinase activator therapy, we know glucokinase is present within pancreatic beta cell, where it acts as a glucose sensor, and it leads to glucose stimulated insulin release at a threshold of about 90 milligram percentage. When there is glucose stimulated insulin release, there is increased expression of glucokinase within hepatocytes, where it acts as a glucose gatekeeper. So when glucokinase is activated, it leads to increased glucose uptake and glucose oxidation within hepatocytes, and also its conversion to glycogen. So if we are activating a glucokinase as a target, this leads to increased insulin secretion, and in terms also leads to increased glucose uptake by the hepatocytes and decreased hepatic glucose output. Now, it has also been suggested that glucokinase leads to glucose-dependent reduction in glucagon secretion. However, this has not been adequately proven till date. So glucokinase activators, these are small molecules that binds to allosteric site of glucokinase enzyme, and it increases its catalytic activity. And this therapeutic target has generated interest since mid-90s. However, it has suffered numerous setbacks, and its development has not been in terms of progress, it has not seen that progress that we would have expected. So first glucokinase activator that was tried was pyroglycine, and the concerns were hypoglycemia, fatty liver, because there is activation of glucose oxidation and increase in malonyl CoA, which leads to increased hepatic lipidogenesis and hyperlipidemia. Now we have two active glucokinase activators. One is dorzaglitin, which is dual acting. That means it acts at the level of pancreatic beta cells and hepatocytes. And then we also have a hepatoselective glucokinase activator. Coming on to the current status, the dual acting glucokinase activator, that is dorzaglitin, has already completed a phase 2 clinical trial in Chinese population, and this study was published in Lancet Diabetes and Endocrinology in 2018. It was found to be efficacious as well as safe, and the mean HbA1c reduction with twice daily dorzaglitin was found to be 1.1% as compared to placebo at 12 weeks. And the phase 3 trial of this is ongoing again by in the Chinese population, and the results are expected soon. This is a 52-week phase 3 trial. The top line 24-week results have already been announced, and it was found to be efficacious, but the full results are expected early next year. Moving on to glucagon receptor antagonism and the background for this, we know that diabetes is actually a bihormonal disease, not just insulin deficiency, but also glucagon excess, and this was illustrated in the Omnis Octet as well. We know that alpha cells are in close proximity to beta cells, and this has been provided by nature so that beta cells secrete insulin and tightly regulate glucagon secretion, and in turn maintain healthy islet insulin to glucagon ratio. The paracrine insulin concentration at the level of islet cells is very, very high. That is in tunes of 2000 to 4000 microinternational units per ml. And this we can never achieve by peripheral insulin delivery. And so we are not able to target the high glucagon levels that are being seen in persons with type 2 diabetes. Although we have GLP-1 receptor therapy, which targets to reduce glucagon level, but it is only successful in reducing glucagon levels by about 10 to 15%. So we have hyperglucagonemia and downstream effects, which are unhealthy in a diabetic patient. So this is a schematic diagram which shows that the paracrine effect of insulin on alpha cells to reduce glucagon secretion, and glucagon acts at the level of liver to increase glucose efflux and cause hyperglycemia. So a novel form of therapy is to antagonize glucagon's action at its receptor, and I'll discuss how this has been done. The strategies that have been developed for glucagon receptor antagonism include development of small molecule glucagon receptor antagonists, monoclonal antibodies that block glucagon receptor, and antisense oligonucleotides, which are in vogue recently, which target the glucagon receptor mRNA and cause its degradation and thus prevent expression of glucagon receptor protein. The concerns with glucagon receptor antagonists which acts at the level of liver are transaminitis, increased hepatic fat, and increased blood pressure, increased body weight, which was seen in initial studies, hypoglycemia, and a concern for increased glucagon levels because glucagon receptor is being blocked. So this can lead to alpha cell hyperplasia and increase in glucagon circulating levels. And we don't know what the long-term effects of alpha cell hyperplasia could be, whether this could lead to a neoplastic development. The current status, 2 oral small molecules glucagon antagonists have actually completed phase 2 clinical trials. The first one was published in Diabetes Care in 2016, and it was found to be efficacious. However, there were safety concerns that were discussed in the previous slide. And recently, another glucagon receptor antagonist, which goes by the name of RVT1502, has completed a phase 2 clinical trial, and this was found to be efficacious with a 12-week HbA1c difference of 1.1% and was found to be safer. However, transaminitis of more than 3 times elevation, significant transaminitis, was still found in about 2% of patients in the latter trial. Moving on to another therapeutic target, that is 11-beta-hydroxysteroid dehydrogenase type 1. And we know that there are 2 isoforms of 11-beta-hydroxysteroid dehydrogenase enzyme. The type 1 isoform is responsible for converting the inactive form of cortisol, that is cortisone, into cortisol. And this isoform is expressed in liver, adipose tissue, brain, skeletal muscle, and lung. That is, it increases local tissue cortisol levels, while the type 2 isoform is expressed in mineralocorticoid rich tissues such as kidney, colon, and salivary glands. And we know that it is important in pathogenesis of hypertension and hypokalemia and Cushing syndrome and some monogenic forms of hypertension. So what is the rationale for inhibiting 11 beta HSD1 is to reduce tissue cortisol level and thus decrease tissue specific gluconeogenesis and unfavorable fatty acid metabolism. And this could have additional benefits for CV risk reduction and also cognition, because it has been found that increased neuronal cortisol level has been associated with cognitive decline. So the 11 beta HSD1 inhibitors that have been tried in the phase 2 clinical trial, which was published way back in 2010, the molecule was found to have very modest glycemic efficacy with the HbA1c reduction of 0.6%. And for some reasons, its further development has been stalled, and there are no further trials after this initial study. The concerns remain that if you reduce tissue level cortisol levels, there could be HP axis alteration, cortisol pulsatility, and diurnal variation of cortisol, which could be altered, which has never been studied in detail. The potential future indications for which this molecule may be tried include patients with cardiovascular disease, CV risk factors, and in patients with dementia, specifically Alzheimer's disease. Moving on to incretin therapies, and we all know GLP-1 receptor agonists have gained momentum in last few years, and now we have GLP-1 and GIP-1 receptor agonists which have been tried. It was always intriguing to know that why GIP-1 agonists were not being used in patients with type 2 diabetes, and a major reason was that the response to incretins is affected in patients with type 2 diabetes and it's actually impaired. However, when you use supraphysiological doses of GLP-1, this impairment in incretin response is actually overcome. Or even when you use supraphysiological doses of GIP, you don't tend to overcome this defect. However, it has been found that when you use combination of GLP-1 and GIP-1, there is a good additive effect and a glycemic effect, and this has been studied. GIP inhibits glucagon in hyperglycemic condition, while it stimulates glucagon in condition of euglycemia or hypoglycemia. It improves lipid buffering capacity of white adipose tissue, prevents ectopic fat deposition, and also potentiates the satiety action of GLP-1. So we are aware that phase 3 clinical trial of dual GLP-1 GIP receptor agonist, which comes by the name of tirzepatide, was published recently in NEJM, and this was a once weekly molecule which was compared with once weekly semaglutide, which is already FDA approved in doses of 0.5 and 1 milligrams. So in these 3 different doses of tirzepatide, 5 to 15 milligrams were compared with 1 milligram of semaglutide. And at end of 40 weeks, very impressive results were seen. This molecule was not only inferior, but was shown to be superior at all 3 doses to semaglutide in terms of HbA1c reduction and also in terms of body weight reduction. And the current status for this molecule following the impressive results is that the manufacturer, which is Eli Lilly, has applied for a FDA approval, and we expect that the results of FDA approval to be out soon. GLP-1 plus glucagon receptor agonism. Now, on one hand, we have discussed glucagon receptor antagonists. This would seem counterproductive that we are targeting glucagon receptor agonists. However, when used in concurrence with GLP-1, there are certain benefits of glucagon receptor agonism, which includes suppression of appetite, enhanced energy expenditure, which could lead to weight loss, and delay in gastric emptying time. And this is a molecule which goes by the name of cotadutide, which has already completed a phase 2 RCT, which was published in JCM in 2020. And it was shown to be associated with significant reduction in glucose, body weight, and increase in insulin levels or insulin secretion in patients with early type 2 diabetes. And so we await further developments on this molecule as well. Dual SGLT2 plus SGLT1 inhibition. Now, this has been ongoing for last few years. We know SGLT1 is expressed in small intestine, where it prevents glucose where it causes glucose absorption, and also expressed in distal segment of proximal tubule. Now, when patients are on SGLT2 inhibitor therapy, there is more of glucose that is shunted to the distal portion of proximal tubule, and this is absorbed or reabsorbed at an increased rate in patients with diabetes. So if you do an SGLT1 inhibition, there is an added benefit of glucose urea that you are getting with SGLT2 inhibitor therapy. And in addition, you get a benefit of preventing glucose absorption. So this is a molecule which goes by the name of sotagliflozin, which is a dual inhibitor of SGLT1 and SGLT2 channels. Now, this molecule has actually completed a lot of randomized control trials. In fact, there is a meta-analysis of 11 randomized control trials, which was published in Diabetes, Obesity, and Metabolism in 2021. And as compared to placebo, this drug was found to be associated with significant HbA1c reduction of 0.42%, and also associated with CV benefits, as was seen with SGLT2 inhibitor therapy, including reduced myocardial infarction, heart failure. And there are individual cardiovascular outcome trials like SCORED and SOLOIST WHF, which have shown benefit in patients with type 2 diabetes and chronic kidney disease and type 2 diabetes and recent heart failure in terms of CV risk reduction. So to summarize, non-insulin anti-hyperglycemic therapy and recent advances, we have glucokinase activators such as dorsagliatin, which have completed phase 2 clinical trial. Phase 3 trial is ongoing. Glucagon receptor antagonist, there are two. The first one, which completed phase 2 trial in 2016, there were some adverse effects. And the new one, which completed which was published recently in 2020. Then we have 11 beta HSD1 inhibitors, the development of which has actually been stalled after the initial phase 2 clinical trials. The dual GLP-1 and GIP receptor agonist, which goes by the name of tirzepatide, which has completed phase 3 trial and approval application to FDA is filed. Then you have cotadutide, for which phase 2 clinical trial is completed, and sotagliflozin, which is the dual SGLT1 SGLT2 inhibitors, and for which we have good glycemic and CV safety data, and which has actually been approved in European Union for use as adjunct to insulin in type 1 diabetes and also in patients with type 2 diabetes. However, it still has not got FDA approval. Moving on to insulin therapy and its advances. We are celebrating 100 years of insulin therapy, and from the first time when insulin was used in its crude form in 1922, we have actually come a long way. We have had several developments in insulin, and the basic premise of the development being to improve the pharmacokinetics and pharmacodynamics of short-acting and long-acting insulin, so that in terms of short-acting insulin, we improve flexibility for the patient, we improve the latency of action, and we improve the postprandial action or reduce postprandial hyperglycemia. While in terms of long-acting insulin, it is our endeavor to increase its duration of action, reduce intra-individual variability, and also reduce nocturnal hypoglycemia. So in terms of short-acting insulin or rapid insulin, we know that there are two newer molecules which have been introduced, which are ultra-rapid-acting insulin aspart and ultra-rapid-acting insulin lispro, and these have come to clinical use. In terms of basal insulin, we have insulin icodec, which is a once-weekly basal insulin, and what structural change has been done in this insulin is that you have 3 amino acid substitutions, namely one in the A chain of insulin and 2 amino acid substitutions in the B chain of insulin. And these 3 amino acid substitutions improve the stability of this insulin molecule, reduces its enzymatic degradation, and slows down receptor-mediated clearance. There is removal of terminal threonine amino acid, and like degludec, you have a spacer and you have a fatty diacid chain, which causes strong reversible binding to albumin and increases its half-life. So this insulin has been tried as a once-weekly form, and a head-to-head study where icodec insulin was compared with glargine insulin in patients with type 2 diabetes has been published in year 2020. And in this study, icodec was found to be similar in efficacy and safety to insulin glargine. And here we can see the efficacy data in terms of HbA1c reduction. This icodec was similar to insulin glargine. And now we have phase 3 clinical trial of insulin icodec, which goes by the name of Onwards 1, which is already ongoing. And we expect that this molecule will be helpful to patients with type 2 diabetes in order to use basal insulin, but with reduced frequency of administration. Finally, I'll discuss oral insulin, which is an oral form of recombinant human insulin. Human insulin has been tried previously in inhaled form. We had Exubra, and then we have Afrezza insulin, which have been tried. We know the limitations. They are only for prandial use, and there are certain limitations in persons with lung diseases or those who have smoking habits. So the oral insulin that this has been developed by Oramed Pharmaceuticals, and with a proprietary technology that is POD technology, or protein oral delivery technology, where they use 3 different components, one being enteric coating of the capsules in order to prevent its gastric degradation, use of protease inhibitors, which prevents protein from degradation by proteases once capsule degrades in the small intestine, and then there are certain absorption enhancers which assist translocation of active ingredients across the intestinal membrane into the bloodstream. Now, the current status for this oral insulin and developed by Oramed Pharmaceuticals is that a phase 2 clinical trial in metformin-treated type 2 diabetes patients was published recently. And in this clinical trial, 16 or 24 milligrams of Oramed capsules were compared with placebo, and these were administered once a day at bedtime for 28 days. This was very well tolerated. However, glycemic efficacy was very, very modest, or actually non-existent. If you see, HbA1c change was minus 0.01% in oral insulin group as compared to plus 0.2% in placebo group. Now, authors have reported that nighttime and 24-hour CGM values were actually increased in both groups, but lesser in oral insulin group. However, that does mean that while this is a very good initial effort, there is a lot of work that needs to be done before we can see the phase of oral insulin. So to summarize, insulin related advancements: once a week basal insulin, which has completed phase 2 trial, and a phase 3 trial is ongoing, insulin icodec, and oral insulin, which has completed phase 2 trial, very modest glycemic efficacy. So we await some better results in phase 3 studies, and this is OMD 0801. So with this, I conclude that the diabetes pharmacotherapy has gained rapid momentum in last few decades, and we hope that the management options, they continue to gain rapid strides in the near future. However, while we await and seek to use newer drugs in the near future, we should also remember that we make use of the existing drugs optimally and judiciously. Thank you for the patient listening, and over to organizers.
Thank you so much. That was really an excellent presentation. So may I now please request our patrons to take over the session?
Yeah, thank you, Sunitra. Is Harshal around? Harshal,
yes.
Oh, there
yes,
you are. Good.
Yes.
I don't see any questions in the chat box, but I think both the talks were excellent. As far as the when you spoke about the smart pump, the one that you have not had the opportunity to use, but you have heard about it and read about it, I think that would be the absolute high-end one.
Yeah.
In which you have the glucose sensor, and which will also tell us how, I mean, will monitor everything.
Yes.
It's like a closed loop. Exactly. That's what we're looking forward to.
Almost, yes.
Yeah. So because the last 5 days we were having daily sessions on public education, and I was the moderator of the one on technology, in which Dr. Uruz from Pakistan, she categorically said that she can absolutely count the number of patients in Pakistan who may be on the pump. But I think you're based out of Pune, so you have good experience. But even then you said I don't think you have any patient who's using the high-end pump.
Yeah, no. So
Yeah.
mostly the
What
basic
is your,
pump.
the ones that the patients that are on the pump, are they type 1, type 2, or what? That is, I think, very important for us to know.
Yes, ma'am. So almost all of them are type 1 diabetics. Two are the LADA, so more or less type 1 only. So almost all are insulin dependent diabetic patients who are on the pump therapy. And there are 3 patients who have been supported by their companies, actually the corporate companies where they are working. So that's why they were able to afford the pump and its expenses. So
What
these are
about
the
the associated support that you need? Are you available 24/7 when the patient is on pump, or you have an intermediary who is able to organize that for you? I think that is very important, because
Yes.
if that is not there, then it's not going to work, because I think it must be taken a minimum of up to 3 months before the patient is actually well versed. And even after that, I think there would be some problems now and then which would be coming up.
Yeah, so there are actually 3-4 persons involved. One is me, who decides or formulates about the basal and bolus as the rates. There is this Medtronics guy who gives all the technicalities or technical related helps, and there is one diabetes nurse educator who we have trained for initial 2-3 months in terms of everything. And we have one common WhatsApp number of our department as such, where patients can actually share their messages or the queries, and that can be forwarded in the group, and we respond accordingly based on the patient's queries. And in case of emergencies, of course, patient have the emergency numbers where they can call directly and get in touch with me or the diabetes educator directly.
I think tomorrow there are a whole lot of sessions only on this, how to set up an ideal diabetic clinic.
Yes.
I think this would be included there. Do you have any pump on loan system? Or the companies, because in between, I think when they had initially introduced it, especially for gestational diabetics, I think gestational diabetes is one ground where a pump would be, I think, for at least those 9 precious months when you want absolutely excellent control. I don't know what is the setup. Is it still possible?
So one patient who is type 1 diabetic who has become pregnant and continued on pump. But on the other aspect, those who are diabetics and develop GDM, no matter how better or well we counsel them, they are not ready for the pump therapy.
Even on loan?
Loan, yeah, no.
Okay. Thank you. So I think Alpesh has told us all about the glucokinase activators, glucagon receptor antagonists, 11-beta HSD type 1 inhibitors, the dual SGLT1 to SGLT2 inhibitors, GLP-1 plus GIP receptor agonists, GLP plus glucagon receptor agonists, and the whole gamut of what is new in the insulin therapy as well. So I think if we still talk, how many of your patients, Alpesh, as compared to before, I'm talking of pre-SGLT2 era, how many of your patients would you, it's very difficult to give a percentage even. Do you think that you're using insulin a little less now as compared to earlier? Just overall, with so many molecules that are coming in, especially the SGLT2.
Yes, ma'am. Definitely, the kind of setup that I work in, we obviously we cater to a lower income population. So even when SGLT2 inhibitors, they were out in the market for last 5-6 years, we had a financial barrier to climb up with. So I would say, while we were seeing lot of SGLT uses in other clinical practice, we were actually not very forthcoming to use because of the clear issue of affordability. But now with the prices coming down, especially the patents gone down, the real use I am actually seeing that the patients who are requiring SGLT2 inhibitors, not only as an add-on glycemic therapy, they are getting it. Definitely, yes, this is a good option, because after 2 or 3 drugs, or say patients are not ready to take insulin, this is a good add-on option, or as a frontline option in patients with established cardiovascular disease or established kidney disease. So now I now that the practice has actually changed, and we are using more of SGLT2 inhibitor therapy. And ma'am, as was discussed, with more advances, we have newer targets, and now we are seeing that you are trying to use more combination therapies where you are targeting two different forms of pathophysiological targets in the same molecule, and that's very interesting and exciting. I think the type 2 diabetes pharmacotherapy will become more competitive in the near future, and that's only going to help our patients.
Because as long as the insulin is injectable, there
Yes.
is going to be a hassle. See, your Exubera, your Freeza, your oral insulin, like you said, is far, far away. Even with once a week or the thermostable insulins, I think we are still far away from at least the injection mode. What I was trying to say is a lot of patients who were requiring insulin, in whom you were prescribing it, and the fact that they're not wanting to take it, I think SGLT2 inhibitors have made a difference in that perspective.
Yes,
You're able to at least make the patient feel satisfied, knowing very well that, yes, this is the time for insulin.
Yes, ma'am.
Yeah, so I think that was an excellent presentation. And the molecule that we should look out for is tirzepatide and sotagliflozin.
Right, ma'am.
Yeah,
Very well,
the
very
two
right.
molecules, I think that are because by the time a molecule is thought of and it actually comes into the market, I think it's a 2.5 decades sometimes. And you know how many molecules have bitten the dust already. So let's hope. So the future is very exciting, and we have a lot to look forward to. I really enjoyed both the presentations. Thank you very much. Over to you, Sunetra.
Thank you so much, ma'am. So we proceed to the next session, which is on delivery of care. So we have now a very interesting session on digital therapeutics by Dr. Tejal Lathia, very well-known name in the field of endocrinology in India. Ma'am is a consultant endocrinologist in Apollo and Fortis Hospital, Navi, Mumbai. And one of her major achievements is being the co-author of the book Language Matters for people living with type 2 diabetes in India. Over to you, ma'am.
It's so nice to see Dr. Sarita Bajaj after a very, very long time. Hello, ma'am. Thank you.
Good to see you.
Always, ma'am. And thank you, Dr. Sunetra, for the kind introduction. I promise I will keep as close to time as possible and will aim to finish on time. Just give me 1 second. I will share my slides. Sunetra, please tell me if my slides are clearly visible.
Yes, everything is perfect. Everything is perfect, including you are looking great.
Thank you, ma'am. So good evening, everyone. And digital therapeutics is the topic that I have been assigned today. One of the reasons that I've been assigned this topic is I have been closely involved in the intervention and designing phase of a digital therapeutic program. And it's my absolute pleasure to talk about it. Now, what I found most interesting is today, because this is a joint ESI SAFEs meeting, and culture makes people understand each other better. With this, we're able to overcome economic and political barriers. But what we understand is that our neighbors, just like us, have the same problems and the same questions. And when Dr. Alpesh and Dr. Harshal were talking time and again, affordability, accessibility were the questions that, were the similar problems that our neighbors also had. So in this setting, I would like to thank the ESI SAFEs for this opportunity to share the stage with so many of our neighbors. And I will take a deep dive directly into what is digital therapeutics. Now, as doctors, we love our classification system, but in very short, digital therapeutics is an evidence-based therapeutic intervention which is delivered from a digital medium to either prevent, manage, or treat a medical condition. What sets digital therapeutics apart is it is evidence-based. Clinical evidence, real-world evidence, publications are required to endorse a digital therapeutic program. It does come under the purview of regulatory oversight, and it is mandatory to support the claims of efficacy with clinical evidence. And an example is a software that delivers a therapeutic option or a therapeutic intervention. Now, today we're talking mainly in the context of diabetes. And digital therapeutic can also be defined as something which is prescribable, which is personalized, and which offers longitudinal care and also looks at outcomes. In the Indian digital health landscape, in the context of diabetes, there are two main digital therapeutic companies, Fitterfly and Wealthy. There's a lot of overlap and lack of standard lexicon, but for the practical purposes, evidence-based therapeutic intervention to prevent, manage, or treat diabetes would be considered as a digital therapeutic intervention for diabetes. It is also prescribed for a host of other conditions, but in the context of diabetes, what a digital therapeutic program can offer is a personalized nutrition plan, exercise, fitness and guidance, sleep, stress management, motivating patients to take their medications, follow lifestyle modification, educating them about their condition, and helping us to monitor people and ensuring that they comply with therapy. So often when I talk about digital therapeutics, a lot of doctors look at me as if, why am I even talking about this at all? And as I go through the presentation, I hope it will be a little bit more clear. So what is the product lifestyle of a digital therapeutic program? Any business idea needs to fulfill one major criteria. It has to fill a need gap in the existing ecosystem. So in the diabetes landscape, you have to identify a need gap, see if it has business potential, assess the opportunity, and then design a therapeutic intervention in the digital medium, decide who can and cannot use this digital therapeutic intervention, form a hypothesis, see what outcomes you want to look at, and more importantly, get expert approval. And this is a very important part that doctors can play, is the expert approval stage of a digital therapeutic program. I think it's very important for doctors to be involved, because we can be the people who ensure the ethical nature of the program, whether it's scientific in nature, it's not making any false claims, and the process is scientifically sound. Of course, like in any other research, there will be a pilot. You look at the usability, you look at the acceptability, you'll go back to the design stage, you'll work on it a little more, and then of course you'll upgrade. Just like Alpesh's beautiful talk on how insulins get better and better and better, that's the same product lifestyle even for a digital therapeutic program. But I think first and foremost, what we need to look at is, as doctors, do we feel that there is a need gap in the diabetes treatment delivery landscape? And for me, this is an unequivocal yes. I think that the need gaps that are there in the diabetes treatment landscape is we have a fragmented healthcare system. We have a fragmented healthcare delivery system. We have an episodic care ecosystem, and I'll explain a little bit about that. We all, across all the South Asian countries, we have a suboptimal doctor to patient ratio. And we all understand that diabetes needs a multidisciplinary care approach. You cannot do it with a single doctor. So in very short, when you talk about fragmented healthcare system, when a person with diabetes walks into the clinic for an endocrinologist or a diabetologist or a physician, we look at the oral medications. Then you need a separate expert for nutrition, a separate expert for physiotherapy, a separate expert for psychology. Along with that, an ophthalmologist, a cardiologist, a dermatologist. So there are a lot of different experts which are required to deliver appropriate care for a person with diabetes, which is not possible for a single patient to access, and it can become extremely expensive. Also, the system of healthcare delivery now in our countries, the South Asian countries, is standalone clinics, many of these which do not have adequate staff. And even if they do have adequate staff, the staff is not trained well, it's difficult to retain staff. So there's a lot of challenge with the healthcare delivery system that exists in our country or the South Asian countries today. We also have something which is called as an episodic care ecosystem. What this means is that the consultation is initiated by the patient. When the patient feels there is a need for change in treatment or upgradation of treatment, the patient initiates the consultation, and then we see the patient. There isn't a consistent system of support, care, and hand-holding that is needed for the patient. Care is based on symptoms. If the patient feels like their blood sugars have gone up, they'll approach you. If they feel that they're okay, even though the HbA1c is 10%, they won't approach you. So there has to be a process where we can follow up patients in the long term, which is where a digital therapeutic program is very, very useful. So the main thing that a digital therapeutic program provides is a beyond clinic support. Once the patient leaves the clinic, all the other small little things that need to be done. The other issue is there's a suboptimal doctor to patient ratio. This means large patient loads. A new patient with diabetes gets about 10 minutes, 15 minutes in the clinic. A follow-up patient gets only about 5 minutes, which is just not adequate enough to do all that you have to do. Now, what happens as a result of this is because there isn't enough attention given to a patient, and I'm not blaming doctors here, I'm blaming the healthcare delivery system, the population that our South Asian countries have, but it often ends up with us losing patients to alternative therapies, promises of magical cure, and I think that this is a very big loss for modern medicine. The last thing is that the multidisciplinary care, accessing a different expert at a different location at a different time, more importantly, the coordination between the various experts. So somebody writes a nutrition plan, does it match their fitness needs? Is it taking into account their stress, whether they're emotional eating? So I think a lot of coordination is required between disciplines. Again, this is a need gap which a digital therapeutic program can provide. So the question I ask you is that where are we today? And I'm taking the example of the largest digital therapeutic intervention for diabetes which exists in the world today, is something which is called as Omada Health. It is a huge company with huge venture, huge capital invested in it. And this is a simple diabetes program which includes a brief check about the eligibility for a diabetes care program. A glucose sensor is given to the patient, and a healthcare coach is assigned to the patient. And this healthcare coach now takes the patient through the entire process of their diabetes care. And if you think I'm joking, about 450,000 members in US currently are using this program. It's also been recognized with the CDC as a way to prevent and delay type 2 diabetes. So it's not something which I'm talking out of my personal experience, but this is something which is accepted the world over. So now let's come to what is the digital health landscape in India. And the current program, the digital therapeutic program, Fitterfly. I'll just give you a very brief snapshot of Fitterfly. So what happens at Fitterfly is, a patient profiling is done, an in-depth assessment of a patient, the medications, their diet, their exercise, their stress and sleep pattern is looked at. CGM data, SMBG data is collected, and then there's a cross-validation of this data in the backdrop of the patient's lifestyle. Identify issues which are problematic. Is it the diet which is the issue? Is it the exercise? Is it a lot of stress? Are the medicines out of whack? And what is it that we need to do? And then the appropriate intervention or corrective actions is taken. One of the problems with digital therapeutic platforms is often they write the doctor out of the picture and completely take over the patient. Now, at least with this digital therapeutic program, the doctor is very much the captain of the ship, and no medication changes are made without consulting the doctor. So nutrition, yes, by an expert. Physiotherapy, yes, by an expert. Psychologist, yes, by an expert. But the medicines are left up to the doctor. And this is extremely comforting for a doctor to know. Also, technology alone cannot be sufficient. So a DTX platform has to be supported by a remote care team with a human face, where video calls, chats, and phone calls are made to patients to make them, also experience the human face of any treatment. DTX platform alone cannot fulfill that need. This program is based on a nudge theory. Gentle, small changes which can be made into habits for a lifetime is the main underlying principle of the program. Now, one of the commonest things that happens when a person goes on a fad diet or an intensive exercise regimen is that most of this is done only for the short term. It's not sustainable. Human beings don't take very well to large changes. They take very well to small, consistent changes, sustainable changes which become habits and gives a person the empowerment to manage their diabetes for life. Progress reports can be sent to doctors. How are they doing in terms of fitness? How are they doing in terms of stress? What are their blood sugars like? And what is happening with the patient? Now, as I said, a digital therapeutic program can only be considered as such if there is evidence, clinical evidence, real-world evidence, and we've been lucky to publish in the Journal of the Endocrine Society. We presented posters at the IDF, and in the ongoing RSSDI, Fitterfly has been awarded the RSSDI USP Award of 2021 for the best innovation in diabetes care in challenging situations. This is not to say that it's the only program out there or it's the best program out there, but what I feel is that any digital therapeutic program that a doctor works with, you have to have that confidence that it's scientific, it's ethical, it's not interfering with patient medications. So that is extremely important. Now, I'll take you in very brief with a typical patient who walks into your clinic. Somebody who's had diabetes, is 50 plus years, 4 years of diabetes, multiple oral medications. Every time he leaves the clinic, he says, "Doctor, pakka main next time hai na sugar control karke launga. Main na exercise bhi karunga aur main diet bhi karunga." And then we all know what happens. The minute they step out of the clinic, in Maharashtra, the state where I live in, Ganpati festival, Dasara festival, Diwali festival, it's done. The HbA1c is not coming below 9%. So the problems that this patient had was a very high HbA1c, he was overweight, and he was on multiple OHs. I've disclosed the name with the prior permission of the patient because it's one of the patient that I have consulted, and we've taken his permission. And of course, with very good nutritional intervention, where a coach calls the patient, talks to them daily, coaches them, nudges them, pushes them to get their diet right, managing pain, improving fitness, and improving the psychological well-being, sleep quality and emotional distress, diabetic distress, or regimen distress, interpersonal distress. When all of these things come together, that's the time that you get beautiful results. And I think any doctor sitting in the clinic, your only intention, the reason you became a doctor is because you want good outcomes for your patients. So this patient's HbA1c dropped from 9 to about 6.3. He lost 8 kilos of weight, a fasting blood sugar reduction from 150 to 120, and could walk up to 6 kilometers without any pain. This one simple case study is just an illustration of the power of a digital therapeutic program, where a doctor sitting in a clinic makes the medication changes, and all of the other things that are needed to get the good outcome are taken care of in a cost-effective manner. So what is the potential of DTX? Continuity of care, coordination between experts, and connectivity. All the 100 million questions that the patient asks you. So today I got a WhatsApp from a patient with type 1 diabetes, "Can I eat Maggi atta noodles?" Now, I don't get those questions anymore if the patient is on a digital therapeutic program. The coach is responsible. They send the queries to the coach. My only job is to adjust the insulin and adjust the medications. So DTX can provide a personalized, longitudinal, multidisciplinary, and outcome-driven care throughout the disease continuum, in this, the context of diabetes. And this has been written up by Dr. Anup Somes, who's a leading industry stalwart in the pharmacology industry, whose main job is to study the healthcare delivery landscape in our country. So the million-dollar question, I'll finish up in the next 2-3 minutes. What is the million-dollar question? What's in it for the doctor? When I'm using a digital therapeutic program for my patient with diabetes, I know what the need gaps are, but what do I get out of it? Well, I think what I get out of it is it saves time. All the 100 different questions that, which fruit to eat, can I eat this, can I eat that, what exercise can I do, how long can I do it, all of these can be taken over by an expert. Because of this, better compliance, better outcomes. My patients feel great, they're more satisfied, they come back to me with happy, and they stay with me. So better compliance, better outcomes, better patient retention. Along with all of this, collection of data, storage of data, analysis of data, you have the scientific proof to say that yes, this works, and this is how you can convince more people to avail of this benefit. But as we all talked about, all of our South Asian countries, cost effectiveness is extremely, extremely important. And in rural areas where experts are not available, money is an issue, they have to travel long distances. I know that internet connectivity is an issue, but I think that's improving in our country. I recently went for a home stay to a small village hamlet, and all the workers in that village hamlet working in that resort all had mobile phones and were constantly watching YouTube videos. So I think we can no longer give the excuse there isn't enough internet connectivity in our country. So it has the ability to be cost effective. I think the most important message that I want to give today is, why should doctors be aware of digital therapeutics, should be involved with digital therapeutics, is because doctors can helm this innovation. We just don't have to be bystanders where your patient comes and says, "You know what, doctor, I read about this program. Can I do it? Is it good?" I think doctors need to be at the helm of this digital innovation. We need to run with it and use it to the best of our abilities for best outcomes for our patients. I also think it's very funny, technology often finds solutions for problems that don't exist. we as doctors know the actual problems, the actual need gaps, and we can drive the innovation and technology to fulfill the need gaps for our patients. I think technology also alone cannot account for the human aspect of patient care, which only you and I can. And above all, to ensure that ethical conduct and scientific approach is the rule for digital therapeutics, and that can only happen as more and more of us embrace digital therapeutics and are involved in the innovation and improvisation. So the bottom line is that digital therapeutics is here to stay, and it's time for Indian and Asian doctors to embrace DTX. And in the words of Steve Jobs, probably the greatest innovation of the 21st century is going to be the intersection of technology and biology. And I think Dr. Singla is going to take this one step further by his discussion on artificial intelligence. Thank you so much for a patient listening.
And I think I should be there. So
Thank you so much, ma'am, for that very lucid presentation on a concept that was almost totally novel to me, and I guess many like me. So we proceed to the next talk in this session. Then we will have our patrons discussing this together. So the last topic for today is about the future, not just of medicine, but possibly of mankind. And we as physicians might have lesser and lesser roles to play in the management of diseases in the years to come. So let's have a look at where this threat to our existence stands at present. So for this topic, we have with us Dr. Rajiv Singla on artificial intelligence in diabetes. Dr. Rajiv Singla is consultant endocrinologist at Kalpabriksh Healthcare, Dwarka, and medical director of OnLive Health, multiple publications and awards. So over to you, sir.
Yeah, thank you, Sunatra, for kind words. A very good evening to senior colleagues and colleagues. I think a great talk by Tejal there. So Tejal, we would be waiting for IPO of Fitterfly to invest in, I think. So all the very best to you. So yeah, so my job for today is to give you a very brief idea on. Thank you. So on very brief idea or an introduction of artificial intelligence in diabetes care. So what I would be covering would be an introduction to artificial intelligence in healthcare. Healthcare poses different challenges. So artificial intelligence has been really very slow to be taken off in healthcare. And then what are the spectrum or the areas in diabetes care that are being affected or being enhanced by, as I would say, artificial intelligence. And then one of the most difficult areas that are still being in a very infancy for even artificial intelligence are clinical decision support systems in diabetes care. And I would try to take all of you through very practical steps in one of our own experiment that we did to develop one of these clinical decision support systems. So what basically is an artificial intelligence is any technique that emulates any machine to do what humans can do using their human intelligence. So there are different levels to the artificial intelligence that any system can be simply a rule-based system in which basically we know that there are very few variables and there is a clearly defined outcome. And then there are rules which connect this input to output in a very clearly defined way. So then we put those systems in the software, and then given inputs, system tells us as to what to be done. Then this is called an expert system. Now the second level can actually be machine learning, where we know what your inputs are, we know what our output is desired, but we do not really know as to how to connect those inputs with output. And as a doctor, we have a lot of instinct and contextual information that we already have. So if we put that in a machine, then machine make its own rules. So and going forward, we'll have an example both for expert system and a machine learning system that's there. And then there is a deep dive into machine learning, which is something called deep learning, in which we just give the data to machine, and then software finds the association itself, and then it tells us that given these inputs, these can be the potential outcomes or association within that data. Now, before we go any further, what we need to understand is that any artificial intelligence is developed on the existing data that we have. And the data in healthcare has been the stumbling block for developing artificial intelligence for so long, and that's why we are lagging behind in practical application of artificial intelligence in healthcare. So the data that we have in healthcare is fragmented. As a patient, my data can be with my one doctor, my drugs can be with my pharmacist, and my lab data can be with labs, and then I have so many other doctors. So it's not at one place. And then if I try to collate that data on one uniform platform, then it's very difficult because every one of us has a different definition for same problem. Like for example, for any patient, I can target for an HbA1c of 7, while somebody else can do it, try to achieve a 6.5, while somebody else can be satisfied with 7.5. And then this data is continuously evolving. We continuously change our goalposts as to what our targets in HbA1c are, and then we develop new drugs. So all the data that was developed based upon previous drugs can no longer be used to recommend the newer drug that's there. So that these are the continuous challenges that we face in healthcare. So as far as diabetes care is concerned, so artificial intelligence is impacting almost all aspects of diabetes care, be it diagnosing diabetes, and then if somebody has diabetes, then predicting whether somebody can have complications. And then if somebody has those complications, so can we identify these complications at population level? And then most difficult of all is the clinical decision support, where we actually have to give somebody an advice, for example, in type 1 diabetes, how much insulin to be taken as a bolus dose. And then in type 2 diabetes, if we are trying to develop a system which would tell us as to what medication to be next used, given what our current clinical conditions are. And then I'll take you through all of them with very small few examples through there. So for diagnosis of diabetes, not only people are using the traditional factors that we believe. For example, family history of diabetes, what my BMI looks like, what my liver enzymes are, what my triglycerides are. People are also trying unconventional way. For example, in one of the study published from China, the investigators try to scan your face and then try to predict whether you've got a type 2 diabetes or not. And then according to this paper, they were successful in by one of those techniques in 99.02% of the time. So that day may not be far that when somebody logs into Facebook and then Facebook starts telling them, selling them artificial sweeteners, because Facebook knows that you are diabetes even before you can imagine that you have had diabetes. And then predicting complications. So for example, in this paper, what investigator did was they looked at your ultrasound image, and then they could predict what your blood creatinine level or renal functions would look like and how are they going to behave in the near future. And then one of the most aspect which is like already reached population and most widely used, and at least I can tell you from my perspective in NCT Delhi, people now go to a lab and then they get a retina scan done through a fundus camera, and in a software would be able to tell them whether they have a diabetic retinopathy or not, and whether they need a further ophthalmologist referral for same or not. So this is one of those things which is like in our face for application of artificial intelligence in diabetes care. Now, one of the things that we need to understand from all the previous 3 examples is diagnosing, predicting, and then detecting those complications is that we only need a cross-sectional data. So whether what your face looks like, or whether you got a family history of diabetes or not, so given your current conditions, we can diagnose whether you have diabetes or not. Given your current clinical parameters, we can predict whether you are going to have some complications or not. But when it comes to clinical decision support system, even to train some software system, we need longitudinal data, or we need clear-cut defined rules that's there. So that's why the clinical decision supports are very hard to come by in diabetes care. Now, type 1 diabetes and type 2 diabetes, we all of us know are two entirely different fishes to be deal with. And then type 1 diabetes, although it's much more labor intensive for the patient and for the family, but if we look at it from data point of view, there are very few variables. There is a clearly defined outcome, and then by and large, those inputs and outcomes can be combined with a very general rules. We have to optimize them, individualize for each person, but then those rules are pretty much clear for everybody. So type 1 diabetes clinical decision support system is a perfect field for some expert rule-based expert system to start with, and when you get enough data, then true machine learning can kick in. Type 2 diabetes is an entirely different problem. It's a very, very complex problem. There are a lot of variables which change with time. And then there are behavioral factors of the patients which impact as to how these inputs are going to impact your outcomes. And then there are multiple medicines to be chosen from. So even most of us experts will not agree as to is there a clear distinction between whether this drug or that drug is going to be ideal in a particular situation. So type 2 diabetes is a great opportunity for us to be using a supervised machine learning, as we call it. So we know what our outcomes are, we know what our inputs are, but the rule connecting those two things is not clear. So we allow machines to make their own rules. But it's not that in type 2 diabetes, the people have not tried creating an expert system, because given so many guidelines that so many societies have. So in one of these papers, which was published in 2015 and was sponsored by Novo Nordisk, what they did was that they made 12 experts sit and gave them 930 clinical scenarios in type 2 diabetes. But you won't believe, in 60% of these clinical scenarios, the 12 experts did not have a consensus. So they could not come up with a uniform recommendations for what is to be next drug to be used after metformin, or what is a third line drug to be used when people are using two different drugs, given their clinical parameters when they were given to these experts. Now, just to take you through a very example for machine learning. So clinical decision support in type 2 diabetes through machine learning needs a pre-existing large data set. And then some part of it has to be longitudinal at least, or there has to be some uniformity in it. So studies applying machine learning for developing clinical decision support system in type 2 diabetes are very, very limited. If you would ask me, there are in single digits, and only a couple of them have actually used the clear clinical data sets to drive their point home. And if I take you through one of our own examples, and then so you can kind of develop that thinking as to how can we go ahead and try and develop an artificial intelligence system of our own so these are the basic steps that we need to go through. Define your problem, then define data that is needed to solve that problem. Then we need to pre-process and transform that data. And then we choose what machine learning algorithm to be applied. And then we apply that machine learning algorithm. And then once we've applied that, whatever results are, we first of all internally validate them, and then we externally validate them on unknown data sets. Now, how do we go about this thing? Is like, for example, for clinical decision support system, our objective was to predict what, given a particular patient's situation or given clinical parameters for a given patient, what would be the next optimal diabetes drug to be used for that patient. So what we did was, because we use our own in-house EMR, so we extracted almost 15,000 diabetes prescription from 5,000 patients, which we saw in our practice over last 5 years. And first of all, what we did was we try to analyze all those factors, and then try to see as to what are the important factors which are actually impacting glycemic control in these people. And what we realized was that patients' behavioral factors were much more important than the diabetes drug that was given to those people. Of course, drugs which were given to people would play a large role, but the behavioral factors was something that we could not discount for, which led to very, very contraction of our data set that we used. We eventually used only around 1,700 diabetes prescription from around 940 patients or so. But these are the factors that we finally settled on. So based upon on the top of what the base background information about some patient is, what's the age, sex, BMI, duration of diabetes a patient has, what are the comorbidities that patient has, but also what the behavioral factor that patient plays in respect to diet adherence, exercise adherence, compliance to medication, what their SMBG log looks like, what's their current HbA1c is. And then we try to predict that, and what their current diabetes prescription is. And then we try to create some rules in which we could predict that if the endocrinologist is not there, then can system predict as to what all drugs to be used in this particular given patient. And then once we develop, so what we have to do is that you have to internally divide data set into 2/3 and 1/3. So in 2/3 we create these rules, and then in the rest of the 1/3 we test these rules to internally validate them. So that's exactly what we did. So just to show you an example, so for example, I want to see whether a sulfonylurea can be used in a particular patient or not, given his or her current clinical parameters. So the machine made these rules, and then the rules included consideration of previous prescription, HbA1c, duration of diabetes, BMI of the patient, behavioral factor like drug and diet compliance, what the fasting blood glucose is, does patient has hypoglycemia in just the preceding time. And then these rules were made for all the drug classes that we commonly use at our clinic. And then when we tried to internally validate it in rest of the 1/3 of data set, what we showed was that 72% of the complete prescription accuracy stood at 72%, which means that the machine algorithm actually was correct in exactly same way as I would have given prescription to these people for 72% of time. Now, the clinical efficacy, we have to acknowledge, can actually be a little bit more, because in a lot of clinical situations, choosing among one drug with second drug may not be feasible. So it may be more. And then, of course, we just try to lay the ground rules. We were just trying to internally validate the system for ourselves. So just one slide on type 1 diabetes. So there is a great artificial intelligence tools on predicting hypoglycemias or hyperglycemias based upon CGMS data. And then there is a great progress on closed loop insulin pumps, where you just have to, the pump changes its own infusion rate based upon what your CGMS or data looks like. However, because these pumps and CGMS data is generally not applicable to developing countries like us, I don't see these artificial pancreas system coming to India or Southeast Asia and people affording it in next 5 to 10 years. What we need is insulin dose calculation on MSI, a comprehensive solution. At the moment, what we see are the piecemeal solutions in the market that are there. We are actually working on a comprehensive solution for type 1 diabetes also, which includes right from carb counting to calculation of insulin carb ratio, insulin sensitivity factors, and then their continuous modification. But I think that's a story for some another day. So just to summarize, artificial intelligence in diabetes care is on cusp of revolution. Diagnostics and prediction based upon cross-sectional data are two areas that are going to see major progress in next 5 to 10 years or so. Managing people based upon artificial intelligence is difficult, and of course doctors are not easy to replace. But what we have to remember is that AI is as good as data, and uniform data collection among all of us can actually change the way we practice medicine. And then if we are able to collate that data and then implement it successfully, so then that can open huge door, and then absolutely can increase breadth, as Tejal eloquently presented here, that once you go on to digital therapeutics, your reach to tier 3 cities, tier 4 cities is like nobody can imagine what can be. And then you can increase the depth of diabetes care by personalizing what drug works for what patient, what kind of diet works for what patient. You can just we can stretch the limits of our diabetes care beyond imagination. So that was all for today. Thank you.
Thank you so much, sir, for that very brilliant presentation. May I please request Dr. Sarwar Malik, sir, for his valuable opinion on this?
Thank you very much. Digital therapeutics by Dr. Tejal Lithia and artificial intelligence in diabetes, both are excellent talks. And I am also a novel person for these talks because these are very novel for me. It may be future very helpful for the patients, but the presenters also point out that it might be available only to a small chunk of people. Although in Southeast Asia, it might be take almost 10 to 15 years to come to this area due to so many reasons, due to poverty, affordability, and understanding of the patients, because this needs to be a careful understanding of the system as well as their input, how to use them. And also there are so many other factors like in rural areas having internet facilities or not. So these may be very helpful in future, might be takes 10 to 20 years. Thank you very much for your excellent talks.
Thank
Yeah.
you.
Okay, so both of you are here. I'm happy, Tejal and Rajiv. So a patient walks into the clinic, right? So what patient profile would you visualize as the type? Of course, you've got your data, right? You have a big data bank, agreed. So from Rajiv's perspective, each and every patient should be on this, yes or no? And Tejal, what about you? The question is the same to both of you. So like you say, you gave that one example of that patient. Why did you choose him? Or you think it can be applied across board? And Rajiv, you specifically said for type 2, sorry, but type 1, yes, isn't it? So then how many are, I mean, the percentage of type 1 versus type 2? So I think you've understood my question. Yeah. Tejal first.
Okay, thank you, ma'am. So yeah, it's a brilliant question, and whenever I talk to doctors about this is exactly what I tell them. So from the digital therapeutics perspective, not every person with type 2 diabetes needs to be on a digital therapeutic program. There are lots of patients who are doing right nutrition. They're very well motivated. They're taking care of their diabetes. So this is not for everybody. But if you ask me 3 patient profiles who do very well with a digital therapeutic program, one is a patient with pre-diabetes or newly diagnosed diabetes, walks into your clinic, doctor, I don't want to take medicine, right? I want to try to manage my diabetes without medication. This is the perfect patient. He's motivated and given the right guidance by multiple experts. This is somebody who can manage the diabetes beautifully, maybe even without medications, using a digital therapeutic program. Second patient who's a very good candidate is exactly like the person I said, multiple OHAs, not managed. Every time promises you, I'll do my lifestyle modification, but is not able to do it. So this is somebody who needs hand holding, who needs to be kind of led through the lifestyle modification journey. These people do really, really well. The third kind of patient, I think, who does very beautifully with this program is somebody who is now needing insulin therapy. So we all have that patient in the clinic. You know for sure they need insulin, but doctor, aap kuch bhi karo, mujhe insulin nahi dena hai. And you bang your head, you do anything. So, Sarah Alam, Rajiv will know her. Today she tweeted about this. One patient told her, ki mujhe death sentence de do, lekin insulin mat do. So that's
what I was trying to corner Alpesh in the previous talk.
Right. So this is a patient who is desperate but is motivated. This person can really be taught intensive lifestyle modification. Then they do really, really well. He is happy. He doesn't have to take insulin. Doctor is happy that the HbA1c is good. So newly diagnosed pre-diabetes do very well. Multiple OHAs struggling to do lifestyle modifications, and somebody is on the cusp of insulin and is refusing to take insulin, they do really, really well. These are the 3 patient profiles.
So what about an on-off? Like, let's come back to the pre-diabetic.
Right.
That means for the rest of their life, they would be on it, or on-off bhi ho sakta hai?
Okay, so see, it's a very good question again. So see, a digital therapeutic program helps you to learn how to manage nutrition, how to exercise smartly, and how to manage stress and sleep. So, but as you know, human beings, when you were talking to Harshal about the pump, so you know what happens when a person is initiated on the pump? The first year is fantastic. They're motivated, they do the SMBG, they count the carbs, they do everything perfect. 3 years later, the HbA1c is back to 9% because they've lost that enthusiasm to do the SMBG, do the carbohydrate counting. Now then, again, they need to be brought back to the track. So I think the same thing happens with pre-diabetes and type 2 diabetes. You do the program once, things are good for a couple of years, then you may need to be reminded that, look, this is what you need to do. So maybe episodically going back to the program intermittently is a great idea. And this is a cost-effective, simple program. You don't have to go to 4 doctors. It's on one digital platform. It's just kind of like having a coach with you full time.
It's like a sanatorium concept. Then you go and like on off.
Right, exactly.
Okay. So Rajiv, where are we? What you said, what diet suits the patient?
Yes.
I think we know absolutely yes, the patient should not have this. But amongst the other, I didn't understand what you meant by what diet suits the patient.
Okay, so I think just to just to give you an overview, I think digital therapeutics, what Tejal is talking about, is an absolutely fantastic concept. And in fact, just to tell you, I am also part of one of that startup, but basically we're not working at the moment in India, but we did a pilot in our own patients to do that. So basically the idea is to bundle entire care and then focus on outcomes rather than just thinking that, right? So when I say the diet fits for patient, is that we all of have this concept of, okay, so if you ask any dietitian, if you ask them what a diabetic diet looks like, then they would say, okay, 6-meal diet. And then I go back and ask them, can you take 6 meals in a day? Then they would come back and say, oh, sir, aisa kaise ho payega? Hum kaam karenge ki khana khayenge? So see, basically we have to individualize for everybody. For somebody, low carb diet can work very well. For somebody else, a vegan diet can work very well. For somebody, intermittent fasting can work very well. So when you go into these digital therapeutic programs, because your touch points with patients are so much, because there is a coach whose time is not as valuable as yours is, and then you have given them some form of assessment in which they can assess as to what would suit that patient. They would come back and ask you,
different
okay,
dietary
sir,
patterns,
yeah. So based upon that pattern, then you can say, okay, go ahead. This is the great idea to be done. And then just to tell you from our very initial pilot that we've been doing for last 6 months or so, for 18 new onset diabetic people that came to us in 1 month, 17 of them 6 months down the line are off medications, and then one patient is on metformin 500 milligram once in a day. So, and that's because we've got those 2 coaches which go back to the patients and then connect to them every twice in a week or so, and then we've got a dietitian which makes a plan according to what suits that patient. So that and digital therapeutic not only tells you to control glycemic, but then there can be internal alarms built for whether blood pressure is controlled or not, whether the LDL looks like in the control, or whether the patient is on statin or not when they should be on. So your overall ABC coverage and prevention of complications in long term goes down. Now what I was talking about was more very smaller subset of whether can these systems eventually make primary care provider empowered enough to give an endocrinologist level care. So for example, somebody sitting in a tier 3 city, and if I devise a system from my own data, and that primary care doctor puts in same data as to what these patients' current medications look like and what its current HbA1c look like, and this patient does this much of an exercise, and the system tells them, okay, it's a good idea to increase the medication, and then if you're considering to increase the medication, then go ahead and maybe use this salt in this much dose. So that's where we want to go eventually, maybe 5 years down the line or 10 years down the line. But then that would have a huge impact on people in tier 2, tier 3 cities. And last thing that I would just like to say is that all these things are already here, and these are specifically meant for us Southeast Asian countries, not for developed countries. We are the people who need to reach, improve our last mile delivery of healthcare, of diabetes care. So these are made for us, and this is the area, this is the region where we need to scale them.
And was this 100%? 100%
cost effective. Yeah, what you said was cost effective. So I want to take that, bring that message home. I think Rajiv, you would say the same.
Yeah, I would absolutely say
on a larger scale, it would be cost effective.
Yes, very.
Yeah, of course, ma'am, because there are, if you look at any patient that you see in your clinic, if you try to divide your time when you are seeing that patient, so you would realize that 60% of time is spent on non-clinical things, looking at their older prescription, looking at what their reports look like, and then you try to remember what you talked to them last time. Now, if I take away that 60% of time, I've already increased your efficacy. So then, of course, it brings cost effectiveness in the system. As a doctor, you get benefit. As a patient, you get better decisions from patients.
Yeah, but then
from your doctors.
Yeah, Tejal said more of type 2, but you said this is not helpful for type 2.
No, I said that devising a very clinical decision support system is difficult in type 2 diabetes.
Difficult, okay.
But these digital therapeutic is different from artificial intelligence that we were talking about. Yeah. My opinion from Tejal is little different. I think you cannot pick and choose which patient to be given this platform. It should be open to all, right? And then we need to individualize we need to individualize that what that patient needs,
Correct.
and then what we feel we need, and we make a consensus, and then let everybody be on this. Because I think even in people, I think, as you said, that first year is the good time. But then even good people who are in remission, or as we call them now, off medications, if we don't keep them in loop, they are going to go off the radar, and then they would be again on
Agreed.
medications
So it's
at some point of
lifelong.
time.
It is lifelong. It is lifelong, no matter what. Irrespective
Diabetes
of
is
what you're
lifelong,
on.
ma'am.
Yes, yes.
Diabetes is lifelong, so then care has to be
Absolutely.
lifelong.
Absolutely. So they need to be on the hook for the rest of their lives,
Mhm.
some way or the other. And I think that makes a lot of sense, that for at least all across the Southeast Asian countries, if we have this sort of setup, it will really make life more comfortable, at least even for the primary care physician, who's not only
Absolutely.
battling with the NCDs, but the communicable diseases as well,
Right.
which just
Absolutely.
don't seem to go away. Zika is coming, then of course dengue is always there, etc., etc. There's no end to that. So I think we've had Dr. Sarwar, would you like to say something before I close?
Thank you,
About
madam.
the talks?
Thank you very much, madam. Excellent talks. I enjoyed really all three sessions, especially the last one session, artificial intelligence, as well as the digital therapeutics. They are all to be, as well as might be, as a presenter said, it may be cost effective in the future. At the moment, it seems to be in preliminary stages. Thank you again for inviting me.
Thank you. So we've had a very, very excellent session on technology for diabetes care and access. Thank you, Dr. Sarwar, for being with us. In diagnostics, so we had Dr. Abbas Raza talking to us about advances in glucose monitoring. Dina told us about the point of care testing for A1C. What is the current status? In therapeutics, Harshal spoke about insulin pumps, basics and beyond. And Alpesh gave us a very good insight as to the emerging and therapeutic targets, whether it's for the orals or whether it was for the injectables. And I agree entirely with Dr. Sarwar when he said that it's not the topic, it's the way the presenters have spoken about it. And both Tejal and Raji, we can't thank you enough, for making our vision less tubular, much, much less tubular. So we can see so many things beyond the way we manage our patients. That's exactly what you wanted to convey, that there is so much out there that can be done to make life more comfortable. What you said, there's save time, better compliance, which will be better outcomes with good data collection, storage, analysis. And of course, at the end of the day, it is also very cost effective. And I liked your quote on Steve Jobs, what Steve Jobs said about biology and technology. When you combine the two, I think then the sky is the limit, isn't it? Thank you. Thank you. Thank you, Sunetra, for the excellent conduct as well. It's been a pleasure having you here. Thank you again to the organizers, especially Dina and Ganpati. Ganpati is the president of ESI and Dina is the president of CEFIS. Thank you all. Thank you so much. A very, very good night. You're lovely seeing you, Rajiv, after a long time.
Thank you, ma'am.
And
Thank you, ma'am. Same here, ma'am.
Okay.
Bye, ma'am. Good night.
Good night.
Good night, everybody.
Good night. Would you like to say anything, Sunetra?
No, ma'am.
Okay.
Thank
Good
you so
night.
much.
Good night. Thank you to the